come up with. Or not, I don't know. Yeah.
Okay.
Hello?
Hi, this is Julia from MPHI. We are just waiting for the group to sign on, and we'll start in just a few minutes.
Hey everybody, thank you for joining us for this webinar. This is Tanika Selik. I'm the McVie lead for Michigan and the Early Childhood Section Manager at MDHHS. I think you guys all know who I am. But I wanted to make sure that I was here to say thank you so much for all of you joining the webinar. We think this is some really important information that you guys are going to hear about from MPHI, and I hope you have lots of good questions and we come to resolutions if there are some issues that we're having with the data. So you can obviously type something in the chat box. We have people here who are monitoring the chat box, and at certain points we will probably unmute lines, so you can also have an opportunity to ask questions. So we're going to, everybody you've ever met from MPHI is sitting in the room. So they're all here ready to help out. So I am going to hand the over to Julia, and Julia is going to start talking about what we are going to do today.
Good morning, everyone. Thank you so much for taking some time this morning to hear from us and talk with us and share your input on where we are with our performance measures for our home visiting work that we do together and that you're doing out there in the field every day. As Tiffany said, we have a whole group of people here eager to hear from you, learn from you, and figure out how we can best support you in gathering what we know are some tricky and complex performance measures. We're really excited to be at the point of being able to share with you where we are today. As we go through the data, we're going to see some opportunities for improvement. We're also going to see some successes, and I want to make sure that we it's that time to celebrate those successes as well as time to notice opportunities for improvement that we have. So one other housekeeping thing that I just remembered as someone signed on, we can mute on our end. One thing that we can't control on our end is if anyone puts us on hold, we hear your lovely elevator music, and there's absolutely nothing we can do to stop it. So if you could please remember to not put us on hold when we're on the call, that would be wonderful. We can mute and unmute on our end. And of course, you're welcome to do that on your end as well. So again, today we have a couple things that we want to accomplish. We want to share and review the fiscal year 17 performance measure data with you. What we'll be sharing includes a couple things. We're going to be sharing what we reported to HRSA under MCV, that you have a chance to see that data and see what we shared with HRSA. We're also going to be sharing data for all of the folks on the phone, which includes everyone that's funded under the Flint water funding, the rural funding, as well as MCV. So you're going to see slides that say MCV and then say all by model. We're also breaking it down by model because we know that every time we present data for everyone as a whole, the first question we get back is, what about our model? And so we did break that down. We want to very upfront caution you against comparing from model to model. Your data collection systems are very, very different from one another. The processes that you're putting in place are very, very different from one another. We definitely, I don't think, are at a point as a system where we can say one model is outperforming another model on any of these measures. So I definitely want to caution you against looking at the data in that way. We just want you to be able to see, because your systems are so different, where each model is standing on each of these measures. If you have questions about that as we go, please don't hesitate to ask. I think this is kind of a cool opportunity to learn how one another do things and collect data on these different measures as well. As we get through talking about the performance measure data themselves, we are going to ask for your thoughts and be here to answer any questions that you have and take any recommendations you have about these data. As I go through the slides, I really hope that you'll make notes for yourself about, I think that we could do this better, but we need help in this way. We are so happy to help you in any way that we can improve your systems and processes for collecting the data, for making what we are asking for clearer, to developing trigger systems with you. A lot of the data are very dependent on time frames, which is so hard. So we're definitely here to help. Just let us know what you need, and please share those thoughts today or after today's call, of course, at any time. We're happy to work with on those things. We're also going to identify some next steps for what happens after today to build on what we have and get stronger by next year. So as a reminder, we are reporting to HRSA under several benchmark areas that were established as part of the Affordable Care Act, and then separately as MCV was pulled out of the Affordable Care Act a couple years ago. These are important not only because they're MCV, but because home visiting at the national level is looking at these benchmarks, at these areas, as sort of their guideposts for what home visiting is and what it does. And the vision for expanding home visiting, both at the federal level through MCV, but also in other funding streams that support home visiting at the state, local, national level, are built on this assumption that if we take home visiting to scale, we're going to see the same kinds of outcomes for children and families that were identified in the randomized control trials that underlie each of your evidence-based models. And that's what's reflected in these bullets. The idea that home visiting improves maternal and newborn health, that it reduces child injuries, abuse, and neglect, that it improves school readiness and achievement, that it reduces domestic violence, improves self-sufficiency, and improves service coordination. So for federal funding, as well as for other funders that follow those federal trends, they're looking at the performance data coming out of MCV, as well as other data that are coming out of the states, to see that assumption is really panning out. If, as you take home visiting to scale, you can see those same kinds of outcomes. That's what these performance measures are intended to signal. You know, to be honest, I think that there's thinking to be done around what performance measures are and should be, and certainly what they should be in the context of home visiting. So this conversation certainly needs to go both ways, of both saying this is how we're performing on these measures, as well as this is what we wish you were measuring us on. And you know, Tiffany is an amazing spokesperson for you at the federal level, and all of us who have those contacts and relationships are happy to bring your voice forward and to say, we really wish that you were measuring our performance in this area because we think this is what really counts. Because I think that there are gaps and there's opportunities to keep improving what the measures are themselves. But that said, our federal funders have had a difficult time using states' performance data so far because we've been choosing our own measures, and they vary too much across the states to kind of tell a consistent story. And so to address that issue, they defined 19 performance measures for states under MCV that were required to report annually. And this was our first year for MCV reporting under those 9 measures, and we're extending that same thinking across the rural funding and the Flint water funding as well. So some changes to keep in mind relative to the measures and the new data collection system. So we have 19 measures, which is a reduction from our 37. Those measures are much more structured, and they are universally defined across all MCV grantees. They include very specific time frames. They are very focused on eliminating missing data to the largest extent possible. They include screening for male caregivers, which is something we hadn't consistently been doing in the past. They include collecting information about all target children. So that includes multiples, that includes each child that's considered served by a LIA. And I think it's important to note that at the federal level, they're still working on making the measures more and more specific. Each of these measures, you know, the devil's in the details, as they say. There are always more questions about what does this really mean and how should we really calculate that. And it continues to put out guidance on how to think about these things so that they are consistent across states. And so you may see tweaks to these measures over time. Okay, let's jump into a little bit of the data. And we're going to just start with looking at the data about who was served in fiscal year 17. So again, I want to say that all includes all NFP, everyone that's MCV funded, all rural funded, and all of the Flint water funded LAAs is who's included when you see all. MCV, we're including that because that's what we reported to HRSA at the end of October. So you can see that we've served 2,639 households in fiscal year 17, and fiscal year 17 is October 1st, 2016 through September 30th of 2017. And those 2,600 households received upward of 32,000 home visits in the past year, which is just incredible. So please pat yourselves on the back for that. That's an amazing number of home visits and a great accomplishment for the system. You've served 2,156 children and 2,648 caregivers in the past fiscal year. Looking a bit about the demographics of who's been served in this past fiscal year. We can see that most of the caregivers that you're serving are younger than 29, and about 40% are younger than 21. So good evidence that you're reaching that younger group of caregivers. If you look at the racial distribution, it might be a little bit hard to see the color breakdown there, but the yellow band is Black and African American, so that is the largest group that you're serving, and the blue band there is the white caregivers that you're serving. If you look down below at ethnicity, you can also see that 13% are Hispanic Latino for all caregivers that you're serving. If you look at gender, I think that's an interesting one to maybe pause on for a second. You can see that according to the data that we have, all the caregivers you're serving are female. We have very few male caregivers for whom we're receiving data, and we wonder about that a little bit. We wonder if we're maybe underreporting the men that you're serving, the fathers that you're serving, the male caregivers that you're serving within your programs. But this is what we see right now. 99% of the of the folks that we have data on are women. If we children's demographics, you can see that you are primarily serving children under 2 years old, and 44% are under 1 year. The racial breakdown is very similar to what we saw for parents, as is the ethnicity breakdown. And we can see that you're fairly balanced in serving male and female children. Caregivers' educational attainment, we see that the largest group there of caregivers does not have a high school diploma, and that second band in green is caregivers that have some college or an associate's degree. As for employment status, that big green band is for caregivers who are not employed, and the blue band next to it, the 20, well, I guess they're both 21%. That's split between being employed full-time and being employed part-time. As far as housing status go, we can see that 81% in our data are not homeless. I want to pause on this particular slide for just a moment and point out those red bands. Those red bands represent missing data. You can see particularly in this slide why having missing data is a little bit problematic. So if you look at housing, it looks like 81% of our caregivers are not homeless. And if we just reported that, we might wonder what's going on with that other 20% of caregivers. We don't know for that 17% missing how they distribute between homeless and not homeless. So it limits our ability to kind of comprehensively tell our story about housing status or educational attainment or employment, or if you look on the next slide, we see the kind of that same issue around insurance and poverty level. When we have those bigger chunks for whom don't have these data, it limits our ability to kind of comprehensively tell the story or understand what's going on with women who are caregivers who are being served by the program. Or children who are being served by the program. So if we look at caregivers insurance, we can see that large group, 68% or 66%, are receiving Medicaid as their insurer, but have a big chunk there that is missing this particular piece of data. Child insurance, we see something similar, a larger percent insured by Medicaid or CHIP. However, we again have a chunk that is missing from this particular data point, where we can't say if they are uninsured or if they are receiving insurance of a particular type. Poverty, sort of a similar story. It looks in our data like 60% of families are living under the poverty level, but we have a substantial chunk for whom we don't know how they distribute between being under 100% of the poverty level and over 100% of the poverty level. That 23% that you see, a good portion of them are just above the poverty level, are in the 133% of the poverty level, that sort of space. So even within that 23%, we have low-income families that you are reaching. Generally, I would say that the demographic indicators that we've just looked at tell us that you're serving the women and children that you're trying to serve. They're younger than 2. They're living in families that have low income, with caregivers who are unemployed or underemployed, that have low educational attainment. We can see that our caregivers and children are mostly African American or white, and that you are also serving a sizable group of caregivers and children who are Hispanic or Latino. So really great evidence that you're serving the population that you're targeting, and some opportunity for improvement around gathering that missing data to help us more comprehensively tell the story of who you're serving. One more piece before we jump into the performance measures themselves. We have some data that we collect. We're calling this family engagement. It's a very small piece of the story of family engagement, but tells us a little bit about families continuing and exiting services. So of the families that were served in fiscal year 17, I'm looking at the all families pie on the left side of the graph. We see that 62% of those families didn't exit before the end of the fiscal year. 7% that were served at some point in fiscal year 17 did exit during that year. So if we look at those families in more detail that exited before they exited, we want to understand how many of them exited because they completed, because they graduated or met your model criteria for having completed the program, and how many stopped services before they completed the program according to your model's definition. So we can see that around 30% completed the program and graduated, and that's phenomenal. That's a wonderful accomplishment. But we can also see that 70% stopped the program before they completed, and we know that that's for a wide variety of reasons, and you're serving families with a complex set of needs. But I want to just point out this particular piece of information and look at any opportunities that we have as a system to change the balance between those two bars in that graph moving forward. So maybe this is a good time to pause and ask if there are any questions. We'll unmute your lines. If you're more comfortable typing in the chat box, that's also perfectly acceptable, but we'll unmute you now and ask if there are any questions. Okay, I'll keep thinking, and we'll save our discussion for later, and we'll jump right into the performance data. So just as a reminder, the performance measures that we're working under this year are new. These are the new 19 that HRSA began requiring for MCV and have been expanded beyond MCV, both within Michigan and in other settings, to tell us the story of how home visiting LIAs are performing in those areas where the research literature tells us home visiting makes an impact. And I think that these performance measures tell us part of the story. I think that there's opportunity for identifying measures that tell us a more comprehensive story of what you do. As we go through these measures, you're going to see a couple things that I want to kind of prompt you to look for up front. Is that we see a pretty substantial amount of missing data in some cases and for some of the measures. And that limits our ability, again, to tell the story in a comprehensive way. Another thing I want you to kind of keep in the back of your mind is that, the models capture data, record them, and report them in slightly different ways. So comparing model to model isn't something that we can do very effectively at this point because of those differences in data collection and reporting. As we get kind of tighter in our data collection and reporting processes, I think that we will get closer to that point where we can see how different models perform in different measures. We're just not there yet, I don't think. Another thing I want you to look at is the degree of variation between the LIA that has the highest performance and the LIA that has the lowest performance. What you'll see in the graph is an average dot and then a line that shows the high and the low. And that is a really important piece of the story that I'll be highlighting kind of throughout as we go, because it tells us about variation. And from all of your QI work, you know that variation is kind of a threat to improvement, because until we get variation under control, it's very hard to tell whether or not you're making an improvement over time. So we'll talk about that as we go, but I just wanted to prompt that up front. So we have two measures that come from administrative data sources, and this first one comes from vital records, this pre-birth measure. So what we got here out of vital records is the number of live births born before 37 completed weeks of gestation, whose mothers enrolled after enrollment, and this is only for the live births that occurred after enrollment to women who enrolled in home visiting before 37 weeks of gestation. So again, we have these really specific populations that we're looking for in order to calculate this particular indicator. So this for children with a documented date of birth or an expected date of birth that occurs within the reporting period. Those are the cases that we look for when we put together those lists that we send you that you check over and make sure that they're right in terms of the mom's name and date of birth and the information for the child. We pull that based on children who have a documented date of birth or an expected date of birth that occurs within the fiscal year. If a child has a caregiver who exits before the birth, those cases get excluded from that list. That also excludes women who enroll after the start of their 37th week of gestation. Postnatally, of course, they're excluded. Only cases that are actually found by vital records get included in the denominator. If a case is not found in the vital records database, they can't find a match, it gets dropped from the denominator. For EHS and HFA, we're reporting each child, including multiples and multiple children who are being served by the program. That will also be true for NFP next year, according to HRSA's requirements. We have to report information on all multiples and all children served next year. We started that with EHS and HFA this year, and we'll move to doing that with NFP next year. So let's look at the dots. On each of these slides, we can't show you the variation by LAA for these because we don't receive that information back from vital records, but we do have the averages. So for the 20% of infants were born preterm. For HFA, 16% were born preterm, and for NFP, 20% were born preterm. We don't have EHS and PAT on here because the denominator was so small that we were concerned that the data would be identifying, so we're not reporting them here. So this is a bit higher. This 20% value is a little bit higher than what we see for MIHP, which reports around 12% born preterm, and a little higher for Michigan, which is usually around 10%. So just to give you a little bit of context to interpret this indicator, which is a new one for us. We haven't looked at this one before. So the next indicator is child maltreatment, and so for this we're looking at the number of children enrolled in home visiting with at least one investigated case of maltreatment since enrollment. So this means that there was a report, and that report went to the point of investigation. It does not mean that that investigation was substantiated. So this does not necessarily mean that child maltreatment occurred. It just means that CPS judged that there was enough information to justify an investigation. The denominator for this measure is the number of children enrolled in home visiting. So this denominator includes all of the kiddos that you served this year, including multiples and subsequent births for EHS and HFA. And the numerator includes all of the children who had an investigated case that was found within the DHS CPS records. For this, the overall average for MICV was 6%. And see the breakdowns by model for this particular measure. We did some work with our partners in Child Protective Services this year thinking through how to pull this measure, and these numbers seem fairly consistent with what you might expect based on home visiting literature in this particular area. I should note that this does not include the all number, which you'll see on all of the rest of the slides, because we don't have those data back yet for all of the LAs. We only have it back for MICV. Okay, now to looking at the performance measure data that comes from your program records. So these are all data that you collect within your 3 different data systems that you're reporting into. All right, so let's start off with breastfeeding. The indicator looks at the number of infants who are between the ages of 6 and 12 months within the reporting period who were breastfed in any amount at 6 months of age. Denominator for this is all of the kiddos aged 6 to 12 months during the reporting period whose mom enrolled in home visiting prenatally. So a couple of notes here. We're looking at only those women who enrolled prenatally and only those kids who reach between 6 and 12 months of age in the reporting period. For this, again, for EHS and HFA, it includes multiple births and subsequent births. For them, if we have a form that's missing that has the breastfeeding information on it, or if the response to the breastfeeding question on a form was missing, they are included, or they are excluded from the denominator in this case, or dropped from the denominator. Okay, so what we see here for MICV overall is that 19% were breastfeeding at 6 months. For all agencies reported, it's 18%. You can see the breakdown by model. We see here is where you can kind of see the line and whisker aspect of the graph, where you can see the top line indicates the agency that had the highest value, and the bottom line indicates the agency that had the lowest value. And we see a pretty big spread here, about 40%. which is really strong for breastfeeding at 6 months. It's great, down to 0%, which suggests some really great opportunities to learn from one another, to share some successful strategies for supporting those moms that choose to breastfeed and want to get to that awesome goal of 6 months of breastfeeding. Our measure is on depression screening. And this one, what we're looking at is kind of we look at two different populations in two different ways. So for those that are not enrolled prenatally, we look at the number of caregivers who are enrolled, who are screened for depression within 3 months of enrollment. For those that are enrolled prenatally, we're looking for depression screening within 3 months of delivery. So we're looking for that indicator that depression screening happened within that very specific time frame of 3 months after enrollment or 3 months after delivery. This year, including both male and female primary caregivers. So if you have information that you're putting into your system about a male caregiver that's being served, we're looking for this depression indicator for the men as well. Includes cases for whom the reporting period includes the date that the caregiver reached 3 months of enrollment, postnatally enrolled families, or 3 months post-birth for prenatally enrolled families. So again, it's like those dates that are really important. We only count screenings that are considered valid. So within various systems that we are looking for screenings that concluded a positive or negative screening result. Sometimes we see like partially completed screening. Those end up getting kind of as not having been completed if they're partially completed. And of course, for those dates that are within that specified 3-month time frame. For AHS, within the system, we're able to tell the difference between a screening that was not completed, a screening that not entered. For the other two systems, we're not able to tell that difference. If a screening's not entered, then we don't know if it was completed and not entered or just not entered. So everyone ends up in the denominator for both HFA and NFP. We're kind of eligible based on those other criteria. So if we look at the data, we can see that for MICV, 83% received a depression screening, and for all, 82% received a depression screening. And this is actually a really dramatic improvement from where we've reported this measure in the past. Last year, 53% of women were reported having been screened for maternal depression. So this is an exciting improvement. So congratulations on this piece. Our child visits. Potentially the most complicated measure that we report on is right here in well child visits. It's pretty complicated, so I'm going to try to talk through it, but if you have questions, don't hesitate to pause me, type a question in the chat box. I'm happy to talk through it. And I feel like every time I say this, I say it in a more confusing way instead of a clearer way. So do my best. So we're looking for the number of children who received their last recommended well child visit based on AAP schedule. So as you all know, the AAP lays out really specific guidelines for when children of certain ages should receive their well child visits. They give a window for each of those visits for when they should occur. And we use those windows as our point of reference for seeing did a well child visit happen within that specified date range. To a child-specific age. So for this, we're looking at all the children served, including multiples and subsequent births for EHS and HFA. And we're also going to need to do that for NFP next year, which is true for all of these measures. I have fairly limited ability to put people into the missing category. So if we have a case that does not have a complete well child window within their date of service, they do get excluded from the denominator. So if you have a kiddo who enrolls very close to the end of the reporting period, for example, and doesn't have a window that closed during their time of enrollment, then they end up being excluded from the denominator. We also are able to exclude FP cases if they don't have a home visit that was documented during the reporting period, or they're missing a response to the question about appropriate well child visits. And for EHS, if the most recently required well child window ends after the end of the reporting period and the child wasn't enrolled services during the previous window, they end up in the missing category. Okay, so it's very model specific, it's very complicated, and you can ask questions now, follow-up questions if you'd like to kind of understand who gets counted exactly in this measure. I think that maybe the most important takeaway is that her expectation is that all of the kids get counted. They are they're very rigorous on this one, and the feedback we got back from HRSA on this one, they asked us again the question of why do you have any children that aren't in the denominator for this measure? So it's important to capture this data as well as you can for all of the children that are in service. So they get counted in the numerator in this case if received their last well child visit within the window specified by AAP. So we're not looking at the window that they're currently in. So if a child is 12 months old, we're not looking for their 12-month visit, we're looking for their previous visit. And we're looking for the date of the visit to fall within the specific date guidelines released by AAP. So for HFA, what we're looking for, we're looking for an item on the target child medical log, which identifies that a well child visit occurred and has a date, and that date fell within the window. We're looking for the well child visit documented on the most recent visit log and looking to see if the date of that visit log happened within the appropriate window. For NFP, unfortunately, they don't have a date for the actual well child visit, so we can only use the date of the home visit as an approximation for that, which kind of even makes that meeting within the window piece more complicated and more difficult. For EHS, we're looking at again, that most recently closed window and on child health outcomes log for EHS and PAT, which indicates the appropriate visit was completed and the date is within the AAP window. So come on, I know, super complicated. Again, I would say that the takeaway is that we're looking for this information on that last completed well child visit for as many kids as we possibly can. And we are looking within those specific windows defined by AAP. So look at the data, and it's really hard for us to know the degree of missing data or the degree to which this didn't take place, because for NFP and HFA, we can't tell the difference. If there isn't a visit recorded during that window, then we can tell if it was just you weren't able to capture that data or if that visit didn't occur. So they both end up being reflected in this percentage. We do here see a huge range by LAA, and much broader than you would expect, from almost 0 children having received their well child visits on time to 60% having received their well child visits on time. So what this tells us is that there's variation across the system in the processes that you have in place for collecting this information, and there's opportunity to tighten those processes and close that gap between the highest and the lowest values. For this in particular, we've reported, this data was collected in past years, but collected differently. What you told us was did the child, you asked at a point in time and you were asked, did the child receive their last recommended visit based on the AAP schedule, and you told us yes they did or no they didn't. And when asked in that way, we were reporting values over 95% for this measure, having received their well child visit on time. So of course, making this measure much more specific is going to fairly naturally result in a lower value, but still this value of 40% seems lower than what we might expect based on what we've reported in the past and just based on what we see in literature. So we're thinking here what we have is evidence that there is some inconsistency in data collection and potentially some need for collaboration across LAAs and support from us, support from Tiffany and Wendy, in thinking about how to make this a routine part of process for asking about this information and getting it entered into the systems. We know that this is a really tricky one. All of these really specific timeframes that are child-specific or mom-specific or dad-specific are very difficult to collect. And we're very happy to support you in that effort. At the end of the day, however, we don't want to report something that we feel is inaccurate and is not good reflection of the great work that you're doing to make sure that children are up to date on their well child visits and have their immunizations up to date and all of that kind of thing. And we think that reporting 40% isn't reflective of where you're at, and we want to be able to reflect where you are accurately. So let us know how we can help you do that. Care. This is a brand new one for us. We haven't reported this one in the past. So for this one, we're looking at the women who enrolled prenatally or within 45 days of birth. They hit 8 weeks postpartum within the reporting period. So we want to see, did that postpartum visit happen? And again, did it happen within this specific window of 56 days or 8 weeks? For this one, we're families or women are considered missing if they don't have, for NFP, if they don't have a home visit encounter form within 8 weeks postpartum. If there's no encounter form during that period, then we exclude them from the denominator. And for EHS, if a child's been born but the postpartum date is missing from the maternal child health form for that child, they end up being missing as well. For HFA, we don't have a way of distinguishing the visit didn't happen, the postpartum visit didn't happen from the data wasn't collected and entered. So that's more difficult for us to exclude anyone from the denominator, so they all end up being included. So we look at the data. Here we see, again, a really, really wide variation between LAAs on this particular indicator, which tells us, again, there is likely some inconsistency in how these data are being collected in the field and entered within the system. This is a total new measure for us, and many of you are getting used to asking about this, to collecting this, to figuring out where to put it and how to enter it. So we might expect to have a little bit of work to do to get this, to put processes in place for making sure that we're able to record this. But we certainly wouldn't expect the true range on this to be quite broad across LAAs. And again, triggers the idea that there's some instability in how the data are collected and certainly some likely missing data on this particular indicator. Okay, tobacco cessation. For a newer indicator for us as well. For this, we're looking at the number of primary caregivers enrolled in home visiting who reported using tobacco or cigarettes in enrollment and were referred to tobacco cessation or counseling or services within 3 months of enrollment. So if they came in and indicated that they were using cigarettes or tobacco, we're looking for an indicator that there was a referral by 3 months of enrollment. As far as missing data, NFP cases come out of the denominator if tobacco status was not documented as a yes or no at intake, and they're also excluded from EHS if there was not a tobacco screening form that was completed at intake. There's some missing data there. For HFA, again, we can't tell the difference between they weren't smoking and the question about smoking wasn't asked. So all of them are in the all women are in the denominator, or primary caregivers, I'm sorry, we're in the denominator. So here, if we look at the data, I want to point out a couple interesting things. We see here that there are many fewer caregivers who are using tobacco or cigarettes than we might expect based on what we see in the broader population in Michigan. And so we have some wonderings about whether or not this for tobacco and cigarette use is happening as consistently as it could at the point of enrollment. And so what I'm looking at here is if we look at FY17, we have documented 123 caregivers who were smoking at enrollment. For all, we have 183 who are documented as seeing at the point of enrollment. And if you think about that in reference to serving 2,658 caregivers, that it's a pretty small proportion that we're documenting are smoking at the point of enrollment. So they're wondering about that, about that data collection. So here again, we see a huge variation by LAA in the percent that are receiving a referral by 3 months, which suggests that there might be different processes for making referrals, different definitions of what a referral is, and or different processes or degrees of consistency in documenting those referrals. We see some pretty big differences by model in this particular indicator as well, which suggests some maybe unique challenges model by model in documenting this particular piece or in making this particular type of referral. And this is actually a topic of the state's current quality improvement project, because we recognize that there's broader system issues in thinking about both screening for tobacco and making referrals for services in this particular area. And I'm actually going to pause there and put Tiffany on the spot just to see if there's anything you want to add on tobacco based on the state's learning.
About, or what we've learned in general.
Just in general about tobacco screening and referrals.
Right. So we are working with our partners in tobacco within the Department of Health and Human Services, and we are recognizing that there are significant populations who are smoking, pregnant women who are smoking in different areas of the state. We are also seeing that as we have done some surveys and done some questions of home visitors, that we have kind of like an equal level of understanding about what is available and what resources are perhaps available to families. So we are about to, next step in our CQI process happen. There's going to be an additional survey. You guys are all looking forward to that, but there's going to be some additional survey about different ways that we might be able to move forward with helping everybody. And so we kind of stopped it there, but we really are trying to be responsive to where we see the areas that have the highest needs, because we certainly want to try to improve overall health, of the women and families that we're serving. So we're trying to be very specific about how we're approaching it.
Great, Tanya. I think it's such a great example of collaboration at the MDHHS level across sections and across divisions, and accessing those great resources that you have in the tobacco section and making those connections to home visiting.
Well, I think tobacco, and then this one is our state level CQI process. So it's MDE, it's the Michigan for Public Policy, it's other areas within our department, so MIHP. So it really is a cross system initiative that we're all trying to work together on that one.
Yeah, thank you. You need to take a drink and rest my voice. Okay. Safe sleep. So this is, again, a new measure this year for us. We haven't collected data on safe sleep in the past. And here we're looking at the number of infants all the way up to a year who enrolled in home visiting whose primary caregiver reports that they are always placed to sleep on their backs without bed sharing or soft bedding. So again, this is including all the kiddos who are under the age of 1 at any point during the reporting period. So even if you had a kiddo who turned 1 on October 15th, they'd be included in this measure. So HFA, we're looking at the data from the most recent home visit within the reporting period and before age 1. And missing the response to one or both questions on the form about safe sleep, then they get excluded from the denominator. For EHS, they're using the safe sleep log, and missing data is including cases that don't have any response on the safe sleep log at the appropriate time point. For FP, they're missing cases that don't have the infant birth form and or the infant health care form for infancy 6 and 12 months, or if they're missing a response to the questions about safe sleep. So we do have some cases that aren't included in the denominator because the form wasn't filled out, the question wasn't answered on the form. If we look at data, we see some interesting things because we see some huge differences by model, which of course triggered us to say, that's really strange and interesting. I wonder why we're seeing that. And what it helped us explore with your help is that for the different models, are asking actually fairly different questions about safe sleep. Well, the questions aren't that different. The answers are different. So for NFP, they give a middle-of-the-road option. So caregivers don't have to say they always do, they never do. Have a sometimes do sort of answer. I can't think of what the response option is. Sometimes never. So they have a sometimes to give a middle option, whereas HFA and EHS don't have that. They have a dichotomous choice, a yes or a no. And I think that what we're seeing in this difference by model is a reflection of that. So for NFP, we have lots of families that select that middle-of-the-road option, that sometimes option. And when given that choice of not having to say never or always, they will say sometimes. For the other models, not having that option, we see more caregivers reporting always. So this is an interesting conundrum, I think, for us as a system in reporting these data, because we certainly aren't reporting something that's consistent and accurate, I don't think, across the board. So this is an area where we have some thinking to do, and might even want to access some TA from HRSA to help us kind of think through how to handle gathering this with greater consistency, this particular piece of information with greater consistency. So this is slightly different than what we've reported in the past, but not entirely unfamiliar to us. So here we have the number of parent-reported non-fatal injury-related visits to the ED since enrollment who are enrolled in home visiting. And looking at visits to the ER for non-fatal injury during the reporting period, as opposed to what we were looking at before, which was a little bit broader than that. And we're missing cases for NFP if they don't have a home visit encounter form at all in the reporting period. And for EHS, ER visits are reported as an as-needed basis, so there isn't any missing data, and that's true for HFA as well. So all of the kiddos end up being counted in the denominator for this one. So this one, we see what looks like a performance. It looks like we have very few child injuries turning up in the ER among the population of kids served by home visiting programs here in Michigan, which is great. It is a little bit lower maybe than we would expect based on what we've reported in the past, although what we were recording was a little bit broader than what we're recording this time. So there may be some visits to the emergency department that aren't getting recorded, and we wonder about that, especially for the LAs that are reporting in the 0%, 1%, 2% range. So there might be a little bit of opportunity to make sure that we're checking in on those ED visits that happen. Child interaction. Again, this is a new one for us, although we have been collecting some information in the past that's collected through observational instrument. We were using the home before, and some are still using the home now. But this measure is really looking at something a little different than what we looked at before, which is that parent-child interaction piece. So the denominator for this is a little bit misleading. We're actually looking at the percentage of those who received an observation of parent-child interaction during the reporting period. So all children served are included in that denominator, including subsequent children and multiples for EHS and HFA. So across models, children are included when they are at the appropriate age for the parent-child interaction screener to take place during the reporting period. For EHS and PAT, I apologize for not consistently saying PAT. For EHS and PAT, cases include target children, including subsequent and multiples, that are served during the reporting period who are 10 months of age or older because of the requirements of the PICCOLO. And let's see. We also are excluding, in addition to excluding children who are younger than 10 months of age for EHS and PAT, we're excluding kids if the PICCOLO form wasn't open. So that's suggesting to us that it wasn't necessarily the case that it wasn't completed. It was potentially the case that it was completed but not entered. They're missing from the denominator. For HFA, we're including all children, including subsequents and multiples over the age of 6 months who had a follow-up form that was due. If follow-up form was missing, then they were excluded from the denominator. For NFP, we're including index children that were born during the reporting period. And for NFP, we really can't tell the difference between a screener not having been completed and not having been entered. So again, all of the eligible children end up in the denominator. And our lawn service just arrived. I hope you can't hear it. Okay, so if we look at data, I think that we are starting at a really strong point with this measure. This is a new one, and generally I think that you're doing a great job in getting these observations completed. It's a new requirement. You're off to a good start. NFP, we know, has some complexity in this one that you're working through, and the requirements that your model has about who can complete these screeners. Which makes this a tricky one, and that's a piece to continue to work through, of course. But overall, for a new indicator, I think that we're off to a pretty strong start. And if you look at that degree of variation we see for EHS and PAT and for HFA, that's our goal. We want to get to degrees of variation between LAAs that's small like that. We see those small lines on our line and whisker chart. The key for a chart. Okay. Language and literacy is also a new one, and for this one, what we're looking at is the number of children with a family member who reported that during a typical week, he or she read, told stories, and/or sang songs to their child daily every day. And for this one, we're looking at all of the children who were enrolled during the reporting period. And what we're looking at here in the numerator is we look for the most recently reported early language and literacy data point that's in the respective system for the model. EHS and PAT cases are missing if that early language and literacy form had never been opened for that particular family. Look at the data. I can see, again, some variation, which suggests that we might not be asking and reporting responses to these questions in a really consistent way across the system. However, again, this is a really new measure. I think we're off to a good start in figuring out how to incorporate this into your processes and models. I just think that we might have some thinking to do at the system level to make sure we're all on the same page about this one. In some of the follow-up conversations that took place over the last couple of months, we heard that this can be a difficult one to figure out both how to ask and how to record the responses for, which might be reflected in some of the variation that we see. I think that this is a good area for us to think about more at the system level and at the state level, and for you to help us think about how to do this in a consistent way. Developmental screening is something we've been measuring for the past 5 years, but in a way that's totally different than what we to do now. So we're now only looking at administrations that take place at 9 months, 18 months, 24, and 30 months. NFP, we look at 10 months instead of 9 months, and for FP, we don't look at that 30-month admission, of course, because kiddos exit at 24 months. So in order to count in the numerator, the screening has to have at least one completed subscale, and it has to have been completed during the suggested administration window for the 9 months, 18 months, 24 months, or 30 months ASQ. Children who have an entire screening window that is in the reporting period are included. However, if we have a child who doesn't have an entire screening window within the reporting period, they are not included in the denominator. So if you had a child, again, who enrolled really close to the end of the reporting period, they might not have a complete screening window for their 18-month ASQ forever, for example, so they would end up being excluded from the denominator. Okay, so let's take a look at the data. This one's super tricky because of the windows and also because of the specific time points for administration. Those were what's required by HFA or not HFA, by HRSA, so that's what we need to work with. But anytime we're looking for an event within a specified time frame, that makes it tricky to collect and enter within that time frame. And here we can't really tell the difference between a screening that didn't happen and a screening that wasn't recorded. But here again, we see a pretty extreme degree of variation, suggesting that there aren't consistent processes in place for either completing the screenings during these time frames, during these specific windows, or for recording that data after those screenings are completed. We heard in the past around 90% of children having received a developmental screening. That the measure that we were reporting on was different than this. It wasn't specific to those screenings, and it wasn't, we weren't looking for screenings necessarily within those very specific time frames. So we might expect that decrease, but I think that this degree decrease from 90% to 60% may be more reflective of missing data and some working through some process changes that is an indicator of actual performance and making sure these screenings are happening. So again, this is one where we don't want to underreport what you're doing, the good work you're doing in the field. We want this to be an accurate reflection of what you're doing. So we can only do that if those screenings are in there with their dates. Indicator. The number of, we're looking here for behavioral concerns, and we're looking for the number of home visits where the primary caregiver enrolled in home visiting was asked if they have any concerns regarding their child's development, behavior, or learning at every single home visit. So this is one where we're looking at your home visit logs, adding up the total number of home visits that were completed, and looking at each of those visit logs to indicate if the family was asked if they have a developmental concern during that home visit. Family in the system that wasn't exited but doesn't have any home visits documented during the reporting period, they are actually included in the denominator for this measure, which is interesting, just something for you to be aware of. That is not a large number of families, but just something to be aware of. Again, this is a really new measure. I think that we're off to a very strong start in performance on this measure, but again, we're seeing that big variation, which tells us not ready to look at these data to tell us if we're making improvement. We need to look at these data to try to tighten processes for making sure we have an accurate number to begin with. We want to see that distance between the top bar and the bottom bar tighten up to tell us that we're getting to a stable process for collecting this information, and at that point we can start relying on that information to tell us if we're making an improvement, to guide us to know if we need to make an improvement. But at this point, again, we see that big variation, which tells us there's some differences in how this is being collected and entered. Okay, intimate partner violence screening is something that you've been doing for the past several years as well. Here we are, one of the big differences is that we're screening men as well as women. And here in the numerator, we're looking for the number of primary caregivers enrolled in home visiting who were screened for IPV within the first 6 months of enrollment. For this one, we have to have a valid screener, so it has to be complete. So if we see one item completed but not the rest, then that it ends up not being counted. And the screener, again, has to be completed within that 6 months of enrollment. For HFA and FP, we don't have any way of distinguishing between a screener not having been done and a screener not having been entered. For ES, if the IPV screening log has not been opened, then we take that as an indicator that the screening hasn't been entered, not necessarily that it hasn't been done. So we do exclude those from the denominator because we have that indicator. Okay, so what we see here, the 78% of IPV of caregivers having been screened for intimate partner violence, this 78% is lower than what we've reported in the past, which has been more like 95%. And that suggests to us, we think it's fairly unlikely that you've stopped doing the screenings. We think that it's probably much more likely that you're not to the point of being able to get all of the screenings that you're doing into your systems, and that the system changeover has maybe resulted in this what looks like a decrease in performance. But again, we want to be a really good mirror of what you're actually doing, so we can report this information very accurately for you. Primary caregiver education is our next indicator. So here we're looking at the number of primary caregivers enrolled in and that maintain continuous enrollment in or completed a high school degree or equivalent after enrollment in home visiting. And here we're only looking at the population of caregivers that didn't have a high school degree or equivalent at enrollment. So this is an interesting one, a new one, and a pretty complicated one. So we're looking at, those caregivers who didn't have a high school degree at enrollment, we're looking at to see, did they stay in school or get a degree? So they don't have to have graduated, they don't have to have completed a degree, but we do look to see if they stayed in school. So the data for this one, we see what looks like a really strong level of performance. 48% of folks that have a degree at enrollment either staying in school or receiving a graduation or graduating within the reporting period is very exciting to see, and 43% for all programs represented in this data. We do again see some variation. We know that we have some missing data on the stats both at enrollment and then probably more of a challenge in documenting that status over time. So we hope to kind of clean that up over the course of the next year, but I think that we're off to a good start in recording and reporting what is a pretty tricky measure. Continuity of insurance coverage is a little bit different than what we've reported in the past. In the past, we've looked at the percentage of caregivers or caregivers and children who have health insurance. And here, instead of looking at having health insurance, we're looking at having had continuous health insurance coverage for at least 6 months. For NFP, we are excluding cases for the denominator if they don't have a home visit encounter form documented in the reporting period. And for EHS, we're excluding cases if the most recently due follow-up form is blank or missing this piece of information. So again, here we see some variation in performance on this particular measure. I think it's interesting to see FA and NFP, the percentages between 76% and 81%, and the whiskers on those two are fairly narrow, indicating we might be, kind of approximating where we are as a system to the degree that these data are being captured. Although we do know we have some missing insurance data around insurance coverage in general, but kind of gives us a sense of where we might be as a system in terms of having continuous insurance for 6 months. That it does look like we have some caregivers who are losing insurance within that time frame. We are reaching close to we have 3 more measures to discuss. Thank you for your attention and for hanging in there with me through these. So complete depression referrals. Here we're looking at the out of those caregivers who had a positive screening for depression within that required time frame that we talked about earlier, so that's within 3 months of enrollment or if they enroll prenatally within 3 months of giving birth. We're looking for the number of caregivers out of those that screened positive who received recommended services for depression during the reporting period after that screening took place. So, look at our data for completed depression referrals. We know from the past, we know from other work that this follow-up piece is so difficult that it really takes a lot of time. It takes having processes in place, having people in place, and systems in place to see if referrals resulted in contact between a family and an organization, or between a person and a depression resource, and that it can be difficult just to gather that information, and then to have systems for documenting it is challenging as well. And I think that more than anything else, that's what we see in this number, because we have such extreme variation between the LAA reporting the highest completed depression referrals and the lowest. We literally go from 100% to 0% on this particular measure, which is quite a large degree of variation. So we know that this is a challenge, and we want to figure out how we can best support you to collect and document those completed depression referrals. With developmental referrals, we have a kind of similar story. However, we have a different and interesting measure for this one. So we're looking at those kids that had a positive screen for a possible developmental delay using the ASQ. So that's our denominator. And in our numerator, we're looking for children who either received individualized developmental support from a home visitor, were referred to early intervention services within 45 days, or referred to another community service appropriate to the child's needs within 30 days. So it's a variety of things, of events that can happen that we can look for to indicate that an appropriate action took place after the ASQ positive screening was identified. So data, again, we see some variation by LIA, and we see variation across model as well that's pretty striking. So again, I think that for this one, having a process in place for following up on referrals and documenting those within these various systems, I think is complicated, and I think that that's where our opportunity for improvement lies. Very last one, IPV referrals. We have really a very similar story here. We're looking at those primary caregivers that have a positive screen for IPV. Out of those, how many received a referral to an IPV resource? Look at our data. We can see what overall looks like a fairly low percentage having received a referral to services. And again, same as we talked about for the last two, we definitely recognize that follow-up piece and documenting follow-up is changing. It takes place at a totally different time than the actual screening takes place, and can be difficult to build those processes and systems. We can appreciate why we're here, especially with the new systems that we're putting in place, and want to support you in making sure that those things are documented, because again, we suspect that probably the referrals are happening more readily than what's reflected in the data, and again, we want to be a really good mirror for the awesome work that you're doing every day. Okay, so some overall observations on data quality. I think that we can kind of summarize a couple areas for improvement. One is that we know that we're missing components on the forms or documentation of screeners and referrals. And we hope that across the performance measures, we can work with you in kind of filling in where we see those gaps. We also, as we've noted, those time-based forms and time-based measures are really pervasive within this set of performance measures. They're really tricky and very sensitive, so we see some gaps around that, around having the dates entered or having the processes in place to make sure that the information is filled out within that time frame that's specified by AAP or according to the ASQ and so forth. We also see missing data collected within the reported, within those recommended windows, especially for well child visits and developmental screening. However, that said, and having noted a variety of areas for improvement and opportunities for kind of streamlining processes and getting some consistency in place, both at the state level and the LIA level and model level, I think that for the complexity of this set of measures, the newness of this set of measures, and both changing to a new set of measures and a new data system within the same year, I think you're all doing an incredible job. We're so grateful for your partnership in this process. As I've said, we want to be a really great mirror for the work you're doing, and I want to know how we can best support you and help you in reaching that goal. So you know I'm a human and not a data reporting robot. I put a picture of my children on the next slide. I know many of you know, it's Halloween, and they were milking cookies for Halloween. And I know many of you saw when I was pregnant for that little one, Felicity, and now she's 3. It's Anya on the left, very patiently being milked with her sister's cookies as an 11-year-old. So thank you for listening to our data report. And yes, I am a real human with real children and not just a data reporting robot. But again, thank you. So let's shift gears a little bit and take the time we have left to gather some of your feedback and answer any of your questions. So we have questions on the next slide, and we're going to open all of the lines up so that we can hear you when you have questions. So all of the lines are open, and you're welcome to speak up at any time or type in the chat box.
No. How old is she?
We are interested to hear about which data points excite you or make you feel proud.
Fine. Up until probably a year and a half ago, now he's starting to like it.
We can hear some friends chatting. I don't think they're answering this question.
Days where they get that bad.
Yeah.
You know what I mean?
So bad. People do things like I can't like.
So can you share with us which data points make you feel excited or proud?
Well, you say like games, like you know how like sometimes you have games that you got on and
Jan, he's been doing the actual.
Out there and data points that excite or make you feel proud. Well, I'm really excited about that maternal depression screening result. I think that's really quite exciting, and I'm proud to see that in the midst of this transition and how challenging it's been that we've made that kind of improvement in completing those maternal depression screenings. I think that's very exciting.
This is Tiffany, and I'm actually really excited with some of those new indicators that we have because we really weren't sure what to expect. They were brand new, and as Julia had stated when she was going over those, they were a little bit better than we expected. Not because we didn't think it wasn't happening, but just because it's a new data point, we just had no idea what would reflect it. So obviously there's always some work to be done, but they started off really strong. So that's another one I think everyone should be pretty happy about, a couple that we should be happy about.
We're a little quiet today, and that's okay. Maybe someone will feel comfortable speaking around which data points surprise you.
Lily from Ingham EHS.
Thanks.
You're welcome. Something that really surprised me was our developmental screenings. You know, as an individual LIA, that's only 50%. That's just really odd to me because those are all ASQs that we have to do anyways for early Head Start. So I'm just shocked that it's at rate. So we need to dig into that a little more and see if there's something that we're not capturing or reporting. And then also with the referrals of ASQs, they 100%, because even if we don't refer them to like early on, the home, there's always supporting them in the home. So there's no reason why developmental referrals 100%, even just as early Head Start in general across the state, we all be at 100%. So those are just a couple things for us that we're going to look into.
Thank you so much for that, and it's kind of validating of what we're thinking here, that the data aren't a great mirror right now of what you're actually doing, and that's our opportunity for improvement, to make sure that what you're doing is cured and that we're reporting it, and you know, we want to be a partner with you in that. So if you're looking at the data and you're like, I really think we have everything in here, then call us and talk us through what you're seeing, so we can make sure that what we're pulling is aligning with what you see in the system. So thank you so much for that, and thank you for speaking up. What other data points surprised you? Hi, Elaine.
Hi, how are you?
How are you?
Fine. I was a little surprised in regards to our early language and literacy activity. I did send a question in, and now I see why it might possibly be at a 55, because you don't count the sometimes, you only count the always. So that makes a little bit more sense. But I know that we were always asking, and that mom is either doing it always or sometimes, and so that made me a little surprised in regard to our number on that one.
The always on that one, and the always on breastfeeding, that's a
Safe sleep.
I'm sorry, safe sleep. Those are high bars, and it is an important clarification to know that what we're being asked to report is that always. But it really should reflect what's happening out there in the world. So, I think that telling that sometimes story is what we want to make sure that we're sharing in our discussions with HRSA, so that they can appreciate the challenges in recording and reporting in the way that they're asking us to.
Right.
Thank you, Elaine.
Especially if there are other kids that's in the household, you know, that's a little much for mom. She can maybe put, you know, if she's got the smaller ones, but if she has a little older ones, you know, got homework to possibly do with the older ones where she can't really get time there to do all the reading and that kind of thing to the younger one. So that's what we're running into. But I'll let staff know so that we can try to get that number up where it's done every day.
And I mean, this is one that we did provide a comment and feedback. Everybody did to HRSA when this came out, and you know, it doesn't take into account kids that are also, not every family has their children in care, but children who are in care are certainly being exposed to reading and singing and talking to and all of those things that we're looking for, but it's not part of the indicator. So it is a little bit of a struggle. It's, as Julia had stated, it's a high bar to reach, and I, as a parent, I would not have reached either of those. I would have been
Absolutely.
I couldn't have been an always. There's just no way.
Right,
but we're going to strive to do everything we can to make sure that we're reflecting what's happening.
Okay, sounds great. Thank you.
Thank you. What surprises you? Or do you see as opportunities for improvement in fiscal year 18? I woke up this morning thinking about this call, and it gave me a stomach ache. And my 3-year-old asked me, "What's wrong?" You know, she, being sensitive little 3-year-old that she is. And I told her that I was going to share this data, and I was nervous about it, and I was nervous that there would be, that these opportunities for improvement that we were talking about would upset people that I cared about, and I didn't want to upset them. And I asked her if she had any advice for me, and she told me xylophone. You know, true 3-year-old fashion, xylophone. That was her great deep advice for me, so that wasn't so helpful. But I know that you are all wonderful partners with us in this process, and know that our intentions are always to do everything that we can to support you and to be, again, a good mirror for the good work that you're doing out there in the field. So our last question for today is, how can we, Tiffany and MDHHS and all of us here at MPHI, help support you with data quality in fiscal year 18? What can we do to support you better?
This is Kim from Genesee EHS. We're already looking at how we can improve or look at referrals for smoking or tobacco cessation. So be interested to hear how you're going to be doing it with the state CQI. But we're looking at what we can do here too on our team level. So we're be interested to hear what you're going to be doing.
That's awesome. Thank you for making that connection point, and I think that's great for the state CQI team to think about how to work with you and partner with you and around that effort.
And I would say, as at the point we're at in our CQI process, where we really are still information seeking process to make sure that we can our first testing cycle, our improvement cycle is going to be effective. We really want it to be effective, but we needed some more information. So if you see information come out from us, from MPHI about this, we just encourage everybody to send back information, answer the questions, or answer their surveys, because that's really what's going to help us know what we can do to be more supportive, because we don't want to just do it like a general blanket. We really want to identify what the root causes are of why we haven't been able to impact smoking in pregnant women as much as we thought we would. So thank you for saying that, and hopefully you'll be able to respond to those questionnaires that come out.
Yep, no problem.
And what else could we do to support you in the next fiscal year? Okay, I'll just, of course, understand that we are here as your partners and to support you way that we can, and so keep thinking about what we can do for you and what you want to do on your end to support improvement in the next fiscal year. This is our baseline from a MCV perspective and from a broader home visiting perspective around these new measures, and I really look forward to seeing where we go from here and knowing how we can best support you in meeting all of our goals for representing our home visiting system as well as we can. So our next steps. We'll continue. We started with our performance measure reports to the end of the last fiscal year. We're going to continue to explore what those look like with each of your teams. Your data TAQI advisor will connect with you, and you are welcome to connect with them. We want to make sure that this process for communicating back and forth about data continues to improve over the course of this year. We know it's really different from what we've done in the past, and we're very open to making modifications and improvements to the process and meeting your needs. So please tell us what those are and what you like and don't like about the process so that we can give you the information that you need to make improvements on your end. And we will be doing some model-specific follow-up because we do know that the data quality issues that we have for the different systems are very different from one another. So we're going to do some follow-up that's much more specific to each of our models represented within our data to make sure that follow-up work with you and data quality work with you is very individualized to your specific forms and systems and processes and model. So that will be upcoming. I see we are at 11:31, so we'll wrap up today just with a huge thank you for all of your effort and supporting this performance measure reporting that we do together as a system. You're incredible and a joy to work with, and I feel very privileged to be connected with this work in Michigan. So very much, and have a wonderful day.